unused. That amounted to about $1,000 per case. And in their field, they figured about $2.9 million could be saved annually if they didn't open disposable products ahead of time. So excess inventory is another huge problem. If you go in your supply shelf, supply rooms in your ORs, the shelves are overloaded with products. And that unused, unopened, expired product is another angle of this huge waste problem we have in our ORs. Now, why do we have so much excess inventory? We as surgeons are part of the problem. Our managers want to keep us happy. They don't want us throwing tantrums when they don't have what we want. And so we need to self-reflect and adjust our own behaviors to minimize this excess inventory problem. The what if emergency that maybe there's a case that will show up once a year and yet they stock boxes of that product on the shelf. The unreliability of the supply chain logistics that happened with COVID and the backlog of products has amounted to people over ordering products that end up expiring on the shelf. And then also, as we go through our VAC committees and engage and bring on new products, no one's going back and making sure that the older products are no longer being ordered. So you have an abundance of stuff on the shelf that is no longer being used and is still being ordered. So the other problem is this trend towards more disposable and less reusable products. It used to be just gowns and gloves and trocars, and now we're branching into anoscopes and proctoscopes. We're now ordering single-use colonoscopes. And what is this all doing? There's this myth that if you use single-use products, it's safer, it's cleaner, it's more sterile, you're going to have less infectious problems, but these are all myths. There's been absolutely no evidence to suggest that that is actually true. And we have plenty of safe ways to reprocess products and without causing adverse outcomes. And if you actually are an environmentalist and you actually care about the environmental impact, the carbon footprint of disposable products is huge compared to reusables. So what is the real financial scope of this problem? A group out of Hopkins actually looked at this and published it in 2015. They went for 3 years and they took every unused, unopened surgical product off the shelf and they shipped it to 2 hospitals in Ecuador over 3 years. And from the cost that they saved and the amount, the dollar value that they actually were able to donate, they extrapolated that if every major academic institution in the US did that, you could actually save and ship about $50 million of products, unused and unopened products, to the developing world. So what happens to stuff we don't use? It all goes in the trash. Now, yet across the globe, elsewhere in the world, hospitals actually can't provide these products for their patients. And why, you would say? Well, it's complicated. Cost is a big issue. We would think that in the lower income countries, the cost of these products are adjusted, but they're not. And I asked my colleagues in Armenia and Iran, who I've worked with, how much does a composite mesh actually cost? It's $500. Here we pay $700. That $500 in those countries will provide rent for a 3-bedroom apartment. So there's no price adjustments for the lower income countries, and those hospitals cannot financially afford to provide these products for their patients. And then there's also lack of distribution. A lot of these countries don't actually have a distributor. So there you have to cross 3 borders to actually find the distributor for the product you actually want. And there's a huge custom tariff, and in some parts of the world, there are embargoes, so they can't even import these products. So how do they work around these limitations? I was surprised to find that a lot of times the burden of acquiring these products is put on the patients. They tell the patient, I'm going to do this procedure. This is the mesh you need, go find it. And they actually have to fly to another country and obtain the mesh or the endomechanical or the energy device they need. And then surgeons and hospitals have gotten creative and they reprocess and recycle stuff that we throw out pretty much every day after one use. And it has also led to innovation. The whole concept of ETEP hernia came out of the lower income countries where they actually didn't have access to composite meshes. So that's how they make do. Now, how did I get involved and get aware of this? Is in July of 2019, I was part of the team with IHC, then went to Armenia, and we did a course, and we did a lot of live surgeries, and I realized that, wow, their back table had no disposables. And everything that we opened that was disposable had what was reprocessed. And then I did workshops for over a course of a year in Iran, which we don't have a political relationship with, so they have embargoes, they can't import anything. And they were handing me ligatures and harmonics that were duct taped together. They've used them so many times, they're actually held together by duct tape. So I came back and I had a huge guilt. Why are we throwing so much stuff out? How can we help those people there? And why are we not aware in this country? So I started first trying to limit my waste and everyone else's waste in our OR. How can you do that? Well, first review your preference cards. There's a lot of stuff on there that you don't use and people are still opening. I put a policy, no disposables are open on my cases until I'm actually there and ask for it. It's okay if I wait a minute for them to open it, but that way nothing is wasted. And if anything's opened and not used, guess what? They hand it to me at the end of the case. As I request new products and it goes through the VAC process, I make sure that the older product is no longer ordered. And this rarely used once a year product, we actually put all of that on consignment. So if it's getting close to its expiration, the company has to come back, the vendor comes and takes it off the shelf and changes it out for another product with a longer shelf life. We can improve our real-time OR inventory system, which I found is very, very difficult. And I've tried to educate my peers like today and use the recycling programs. But so how do I go back? I don't know. Anyway, so then one day I got an actual phone call from my friend in Armenia, and he asked me for one open and one laparoscopic ligature. I said, what the hell difference would one ligature make? And he said, believe it or not, it'll last me a year. And here I was in the OR. We had literally that day thrown out 20 ligatures when I walked from room to room. So that first shipment started in September of 2019. I spent a couple of days, went from room to room, asked my cases, collected all thermal energy devices, endomechanicals from non-infectious cases, stood in the washroom, power washed all of them out, dried them, collected them, packaged them, and sent a whole suitcase to him. And to this day, 4 years later, he's still using them. So then as I started collecting unused and expired products, I told all my managers, give them to me, don't throw anything out. My garage became full of this stuff to the point where I can't park my car in my garage anymore. And then calls started coming. There was a war in Armenia. There was an earthquake in Haiti. There was a war in Ukraine. And people who knew through word of mouth I'm doing this started asking me for products. And then I spent hours on weekends sorting, packaging, and shipping stuff abroad. And it's been very gratifying, very fulfilling. And over the past 4 years, I've sent hundreds and hundreds of boxes of supplies, from central lines to dialysis kits to GI lab supplies, orthopedic, surgical meshes, staplers, endomechanicals, everything. So there are hurdles. I'm not gonna, make it all rosy. On our end, the biggest problem is the OR administration, and the OR and hospital administrators are so afraid of liability. And so I found the less people involved, the easier it is. And I've had to reassure them, we're de-identifying. There's nothing on these products that says it's coming from Torrance Memorial. No one will know where it's coming from. It's just coming from California, a good Samaritan. And I found on the other end, governments are proud. They don't want to allow expired and, used products, even though they know they need it. So it's challenging to get around governmental bureaucracies, but if you deal with the surgeons and hospitals directly, they will always find a way. And shipping costs can be a burden. Customs and tariffs at the other end are a burden, but when there's a will, there's a way. So my call to action is that now that we all know better, we should do better, and we can change. We can't change the system, but we can change our operating rooms one case and one surgeon at a time. Thank you very much.
Want to take some questions?
Any questions? Yeah.
Want to come to the microphone? Do you mind? Thank you.
reduce waste kind of across a group or a practice?
Well, I think a lot of our VAC committees try and do that. The problem is that people like what they like, and it's very difficult, and you can't start this process, confrontationally. So you want people to buy into it. And so what we've done is try and get a real-time usage data. So if I like Ethicon and you like Covidian, how many do you really use? How many do I really use? Why do we need to order 200 of everything when I only use 20? So I think it takes more manpower to get real-time inventory, but I think that's where the money is, because if you alienate people from the get-go, telling them you cannot have what you want, that you've lost them before you even started. Yeah, go ahead.
Kamal Itani from Boston.
Nice to meet
A
you.
very nice presentation
Thank
and
you.
great work.
Thank
At
you.
my hospital, when the date of expiration appears on the package, we have to throw that disposable
That's
or
every
that
hospital.
mesh or that suture.
Mhm.
And what a waste.
Mhm.
Has anybody looked or studied using these expired disposable sutures, meshes, and see what happens?
So they use it where I ship them, they use it. So I've shipped.
But there were studies, looking
So
at the effect and what happened.
I haven't seen studies personally, but I'm sure that's something we can all work together with to do this,
we
because
should.
yes, there's data on how much waste we have, but in this country, because we can't reuse those products, there really isn't studies coming out of here, but I bet you if you look probably internationally, there is. The other thing is pride is a real big thing in this conversation. And when you talk to people in the other countries, their governments and their, medical boards and stuff do not want to acknowledge that they are using expired products. We all know expiration dates are arbitrary and they mean nothing, but they don't want to admit it. But I can tell you that they use these products. When I ship them, I've shipped biologic mesh, Stratus mesh, that's $10,000 a pop. I mean, they were literally going to throw that out. I got 10 of them. They were throwing it in the trash. Give it to me. I gave it to a passenger. They took it. They've used it. No adverse outcome, but it takes a very gutsy surgeon to actually write that up.
Thank you.
Go ahead.
Hi there, Bumsy Ali, Penn State. I think one thing for some of the non-perishable items like meshes, a lot of it is stability for packaging and sterility concerns.
Mhm.
And, certainly the cost concerns and being able to rotate stock out with your vendors is phenomenal from a cost containment standpoint on an institution. But sometimes you can even have conversations with those individual vendors and they have extended stability tests that even if it's not on the packaging, that based on lot numbers, they can tell you these are actually still good for X amount of time. So it's a very.
Have you been able to convince your hospital that you can use those if it's past the date on the package though?
So it hasn't come up in that context, but in the
Yeah.
context of, a misrecognized expiration date and then whether or not that needs to be replaced, after having already been on
Yeah.
the field.
No, you're right. I mean, again, like I said, people use them all over the world and without adverse outcomes. Some of them they reprocess, some of them they don't. But you're right that, we all know, just like the aspirin off of the shelf, that you can use it way past the expiration on the bottle. But to actually get people in positions of power to actually acknowledge and okay it, it's really hard.
Don't try this with yogurt. I'm just gonna,
Huh?
don't try this plan with the yogurt.
Yeah.
Yeah.
Thank
All right,
you.
thank you very much. All right, next talk is titled Inguinal Hernias in Elderly Patients by Dr. Cavazola and colleagues from the Universidad Federal de Rio Grande do Sul.
So thank you for the invitation. Probably when we're going to talk disparities here is the way we treat this patient, different from younger patients. So the idea will be try to understand why, why we do this. These are my disclosures. They probably won't have any influence in what I'm talking about. What is old for you guys? For the World Health Organization, older is someone that is 60 or more. I can see a bunch of older people here. And old people here and some ones that are getting close to. So it depends on what are your standards. This talk will serve for you all. Why aging is so important for inguinal hernia? This is the lifetime occurrence, which is well known for all you guys, but there's something very interesting when we go through our public systems. There's a huge increase in life expectancy. In the world, in the 80s, people more than 80 years old, they account for 54 million people. Today, probably there are 150 million people. So it's a threefold increase. The problem is the incidence of inguinal hernia, as you all know, can raise with age. And that's the incidence in people over 80 years. So 35 to 44.8%. Just to give a short example, China has 35.8 million people over 80 years old. If you turn these numbers, you're going to have 1.2 million people that need surgery. It's more than the American market for inguinal hernia. So we have to understand what we're going to do with these guys if we're going to do the same surgery that we are used for. All of us know that the morbidity for elective surgery is different from an emergency surgery in general, and in inguinal is not different. And there's a lot of concerns today about patient outcomes and quality of life measures. So we don't have any consensus on how to manage these populations, because the consensus say that we have to use patient-related specific conditions such as age to tailor the procedures. There's something interesting. The only consensus that I could find is that we should avoid to operate nonagenarians because they have like a 10-fold higher mortality. So watchful waiting probably is much better than operate these patients. So if we go there's something very important that the last question on this consensus of all the international guidelines, everybody says, okay, we have to do local anesthesia for these patients. And this is the only one thing that didn't get consensus on these papers. So it's very important to understand that with the advance of anesthesia, we deal better with these patients using general anesthesia. And so we always have to understand that there's complications, and the timing of surgery should be discussed based mostly on patients' comorbidities than just on their age by itself. So should we operate all elderly patients? This is watchful waiting that say that these patients did well, but after 10 years, more than 2/3 cross over to surgery. And this is very important to stress that acute hernia problems were rare in this population. So, okay, it's safe, but at least if we follow these patients for 10 years, 2/3 of them will turn into surgery. And if you go to a specific man aged 50 or older, which is like our population, is the median was 65 years in both cases. When we see the patients that crossed to surgery, which was 93 patients corresponding to 36.2% of the patients, there's no difference in the outcomes when we follow these patients, showing that watchful waiting is a reasonable alternative. So if we have a lot of papers showing that this is okay, why elective surgery? Okay, when we go specifically to hernia repair, we can see that emergent repair has more morbidity, more mortality, and it increases when we increases the age. This is a paper that collected data from NISQIP. So there's a suggestion that elective hernia is preferred. Why? Because we will avoid the complications of having some patients operating in emergency setting. But it's very important to understand that we should optimize these patients. Pre-op optimization is key for these patients. So we went and did a systematic review of where are the outcomes for emergent groin hernia repair in older patients, more than 65 years? And we realize by going through all the data on the literature that you can see the complication rate was very big. It was 21 to 20, almost 29% of these patients had some complications. And the mortality for inguinal hernia can be as high as 60% and was greater in the groups with more than 75. So we suggest that elective surgery is acceptable and less harmful over watchful waiting if we think only about the patients that had an emergency procedure realized. So this is very important to stress. But we should always discuss with our patients based mainly in their clinical scenario to discuss with them if surgery is good for them. So, okay, going through all this, we decided that we're going to operate this patient. So which kind of surgery? Open, lap, okay. So this is a paper showing that patients had a lot of small complications like urinary retention, seromas, doing laparoscopic surgery. But these patients had a better quality of life outcomes, especially in the short-term period. So the conclusion of these authors is that besides having all these drawbacks, probably laparoscopic repair is a good option for these patients. And we have another paper showing that you have a decrease in length of stay for these patients, and laparoscopic are both feasible, but probably MIS can be a suitable option for a lot of these patients. The decision should be made in patient conditions, but again, let's remember that MIS requires expertise from the surgeon. So we have to tailor these procedures. And with that, and to maintain my time, I will take home message for you is, of course, the aging is a fact, and we are dealing with a disease that has an increased incidence with age. We saw that watchful waiting is acceptable, but in 10 years, 2/3 of the patients that will get old by these 10 years will cross over for surgery. Elective surgery has better results as we show it than emergent repair. Of course, we have to have these patients in good shape. MIS is a trend for these patients, but we have to tailor this based on patient and surgeon characteristics. And as I showed you, probably in nonagenarians, since there's a 10-fold increase in mortality and morbidity, watchful waiting is perfect. Thank you very much.
So the problem that I have is my anesthesiologists want me to work under local in the oldest patients. And I think we all understand that the people who benefit most from MIS are the sickest patients.
Agree.
And so on a day-to-day basis, how do I convince my anesthesiologist that, no, we're not going to do this under local, even though it's going to take longer, because they're going to get a benefit in the long term. They're thinking today, and you and I are thinking the rest of the recovery.
Yeah, I totally agree with you. I have a very close relationship with my anesthesiologist, and we discussed this a lot because, as you know, I work in a public health system in Brazil. I work with the worst cases. So in fact, today, my anesthesiology prefers to do the toughest cases under general because he can control more the patient. That's the way he came to me and talked about it. So I don't have this problem, but
Is he
I
available
understand
for
why
consult?
Yeah, I totally agree with you.
For general anesthesia, do you recommend TIVA or gases for this set of patients?
Most of the patients are doing only under IV anesthesia with for
TIVA.
for these very sick guys, because they can control, and they are using some new non-invasive platforms that they have right now that are very useful for these kind of patients.
And Eric, for MIS, well, in my practice, I try to do a very low pressures using the air seal. I don't know what's your experience.
Our regular for every patient is like at least maximum 11, 12. And for these patients, we try to do it with 9, 8. And it's feasible because they have a more complaint abdominal wall, so it's easy to,
It's easy to
yeah,
distend it.
to achieve it.
Thank you.
Are there people you will not watchful wait? The people in my practice who I get the most concerned about would be someone who has maybe the beginnings of some dementia where they may not report the hernia, somebody who lives in maybe a nursing home where they may not be receiving the same care as if they lived alone. Are there absolutely people where you say, I understand, here are reasons to not watchful wait?
Yeah, that's a very good question. Probably if you have someone that is a nursing home, that there's someone taking care of him, this guy you can watch with, it's easy to watch this patient, but I totally agree with you. The inguinal patients that has incarceration that can't reduce the hernia, probably there's a subset of patients that you will operate from first. I think the idea that I talked, thinking about this lecture was, I think we probably do the same with the old guys that we do with the young guys. That's why the disparity came to my mind to do the lecture.
Last question.
Marco Giorgi from Brown. Thank you for that. Do you have a different pain regimen for these elder patients when they go home compared to others? And not just talking about, watchful waiting. In Brazil, like in Italy, it could be different because you maybe don't give as many narcotics, but in the experience, the older patients tend to need less than younger. So do you have anything specific for those people compared to general population?
I mean, I think the most important part of your talk is that we are completely different from America. We try not to use opioids in these patients. So as I told you, I have a close relationship with my anesthesiology, and they prepared. It's different from each patient. We use a lot of locals, even if it's an MIS, we use tap blocks, we use rectus sheet block. And this patient, usually with MIS, they do very well. So we try not to use opiates. And our use, I can tell you, is completely different from here in the US when I see your prescriptions.
You don't get to be 90 by being a wuss. All right. Thank you very much. Up next is Dr. Heidi Miller. Dr. Miller is an attending surgeon and the associate program director at the Maine Medical Center. And she will be continuing on the theme with sex disparities in hernia for both treatment and outcomes. Dr. Miller.
Hi, thank you for the invitation to talk. This is like speed dating with these 8-minute talks, but I've no disclosures except that I'm a woman, and that may have colored my talk today. Let's see. So I want you to imagine you're walking into your office. It's a busy Wednesday clinic. You've got a full panel of patients. Walk through the door, get ready. The first patient you almost run into because they're studying the chart that happens to be placed right in front of the door. This has happened to me, obviously. And then you get them to sit down in the office and you talk to them, and it's somebody that you've just heard about who looks like this. They come to you with a minimally symptomatic inguinal hernia. Maybe their wife is bothered by the bulge more than they are. And they want to know whether they should be watchful waiting, whether they should have surgery, how you're going to approach it. And the question I have for you is the conversation you have with this person different than the conversation you have with this person? If they're coming to you with the same similar complaints of a small bulge that's minimally symptomatic, and what are your thoughts and how do your conversations change? And as we saw in the last talk, all of the data that we have that has colored and given us information on how to provide these questions and answers for these patients and to decide on treatment pathways have come from studies on men. And that was a perfect setup, Leandro, thank you. But there are at least 5 studies that have looked at MIS versus open and watchful waiting versus surgery that had over 4,000 patients in them. 14 of them were women. And so that's less than 0.5% of women in these studies. And yet we're using these studies to extrapolate and make decisions about women. and it's not just in our research, it's also in how we educate and how we learn and how we look at anatomy. Have you tried to ask a resident to describe the triangle of doom when you're doing a minimally invasive hernia repair on a woman? They can't. They cannot figure out how to describe that triangle and replace the vas deferens with a round ligament, or that would be something to think about. And I'm guilty of this. These come from a publication of my own. But what we do know is that female patients are different. And in inguinal hernia, we actually have more data than we do in most hernia. We've been looking at this a little bit longer. We have data coming out of Europe. There are recommendations from the European Hernia Society that have been longstanding for recommending minimally invasive repairs for women because of their higher likelihood of having femoral hernias, their higher risk of recurrences and missed femorals. The other thing we know about women is that they have different risk factors that lead to their hernias. They have higher rates of constipation, asthma, and acid reflux, and their BMIs are different as well. And then they also have different outcomes. If you do a Lichtenstein in a woman, she's more likely to have a higher recurrence rate, complications, and higher reoperation rates. Probably it's because we're missing the femoral hernias that we know that they have. And yet 50 to 65% of women in the US in studies, only 50 to 65% of women actually get minimally invasive repairs here. So we have standards that we know from data, and yet we're still not following through with those. And I think also importantly in your discussions with them, there's good data to show that women have higher rates of pain and complications in both acutely and long-term after inguinal hernia repair. So this leads into something that's kind of come to light in the late 2010s, and that the majority of scientific research has studied men historically and moving forward, but not just male humans, male sexed cells, male sexed animals, and then male sexed humans. And that has come to light in some research looking at studies, and has also been true in the surgical literature. There is this nice study that was published that they looked at 1,300 studies, and only 38% of them even use sex as a biologic factor. Only a third of them actually analyzed by sex, and less than a quarter of them included it in discussion. But women aren't just smaller men. And we know that because there's a lot of biological differences that are genetic based, that are metabolic, that are hormonal, and are also physical in our structures and statures. And that has led the National Institute of Health to make a mandate that all research moving forward actually includes sex as a biological variable, and that it should be included in research design, and the question should be asked of how this affects what they're looking at. So that has led to some increased interest, I think, in the topic. And as you can see, there's been higher number of publications looking at sex in ventral hernia. Although most of them, because we're in the very early stages of this interest in the topic, are very descriptive. They come from single institutions, they come from registries and collaboratives, and they're almost all retrospective. There are a few prospective studies out there, but not very many of them. What we've learned from that so far is that the women undergoing ventral hernia repair are different than the men. They have different baseline characteristics, and also different risk factors for hernias. They're more likely to have more abdominal surgeries, and that's because of gynecological procedures. Their incisions are in different locations, so their hernias are in different locations, and they're usually different sizes. They have different needs and different access to care. They have a higher requirement for component separations in many situations, and get more paniculectomies. And a lot of that comes down to fat distribution and just the way that the gynoid and android fat distribution is different. When I put these patients up here, they both got robotic flank hernia repairs from me, but if you look at one, you can tell who is male and who is female just based on their fat distribution. And this affects also inflammatory markers, hormones, as well as the structure of the abdominal wall, and the considerations that we have to think about when we're deciding how to approach these hernias. women and gynoid fat distributions have much thicker subcutaneous fat volume, which is associated with higher risk of wound infections, need for paniculectomy, and other complications, and then also affects the volume of the abdomen and the compliance of the abdomen that may require more component separations for repair as well. And I'll tell you, full disclosure, that picture on the left of the CT scans is the same woman pre and post Botox, which is a different discussion, but I thought it was an interesting visualization of the difference of the intra-abdominal versus hernia volumes and how we can create change with some of the adjuncts that we have to help with that as well. Studies have looking at the surgical technique and treatment approaches basically have been inconsistent. Some of them show that women get more laparoscopic repairs. Some of them show that they get more open repairs. Within the Michigan Quality Collaborative, they actually showed that women of childbearing age did not have less mesh placement, but women overall did. And so the other thing we need to do as we're looking at this is look at the whys and what the underlying factors are. The assumption is that women get less mesh because we're considering their childbearing status, but that's actually not what these two separate studies are showing. So it's coming to light, but it's not consistent. There's evidence that our protocols of optimization actually contribute to disparities. Women are more likely to have higher BMIs when they present with hernias and therefore are told no more frequently. And the outcomes research is also just now starting to come to light, and it's very basic, but consistent with the inguinal hernias, women have higher rates of acute and chronic pain. And there's at least a trend towards increased recurrence and complication rates with ventral hernia repairs and the female sex as well. So the end statement is that we don't know, but there are disparities and the research is still coming. We need to study this and we need to include it in all of our research. But then beyond that, we need to look at the whys. When we do find differences, what is the basis of that difference and where can we affect change? And then also to implement the evidence in your practice once it's established and we know. So provide minimally invasive hernia repairs and for inguinal hernias for women because they have better outcomes. Thank you.
This paper is open for discussion. A quick question about the implications of next steps. Do you find that ultimately when you counsel women, do you counsel them completely differently in the office about what to expect? And is this something that you counsel your residents and other trainees to do as well?
I do. I think it's hard because we just don't have great data. So I actually am very straightforward with my patients about that. When I talk to them about inguinal hernias and say, we know that in men we can watch care safely, but we actually don't know if that's true in women. And the evidence shows more likely that you're going to end up with an emergent problem if we don't fix it. But I also don't know enough to tell you whether that's going to happen to you or not. And the chronic, the pain aspect after hernia is, the data shows that it's true. What we don't know is why. And that's another thing that I tell my patients. In men, we know that most post-op pain after inguinal hernia, or a lot of it is related to technique, but we don't know whether that's true or not in women. So it does change how I talk to them, but it also makes me feel like we don't have enough information to be straightforward with them as well.
Hi, my name is Nan Wu. I'm from Milwaukee. I train with Igor Biliansky. So in my practice, I see quite a bit of diastatic recti women with very small umbilical hernias with very narrow rectus spaces. So ETEP, while I would like to do that, can be challenging for a space to get in. So I'm just wondering from a technical standpoint, what is your approach for those in an MIS way? Because I don't really like doing TARS to, be able to have that wide mesh overlap in a skinny woman who has a BMI of 23 with a rectus space of 5.
Mm-hmm.
So that's just an ongoing challenge. So what do you do for those?
So I actually really like those cases, and I do a trans-abdominal approach and incise the posterior rectus sheath and come across the midline. And then I just use a narrower mesh, but I do a little bit more. I secure my mesh a little bit more because it's narrow. It's also, once I close that flap, there's really nowhere for the mesh to go. And I have a pretty large series of them that I should probably study and publish, because that's my favorite approach for those women with diastases and umbilical hernias. And at least anecdotally, I've had very good results with that. The question had been are you weakening the posterior sheath by incising it? And I have had zero breakdowns of that flap or recurrences from that. So I think, at least in my experience, it's a safe way to go about it. And it is hard to work in the ETEP space with such small space to work in.
Actually, more of a comment than a question. I find in my practice, the biggest disparity is actually recognition of hernias in women. I think a man shows up with groin or pelvic pain, the assumption is automatically that it's a hernia until proven otherwise. But a woman, the first referral is to a gynecologist. And it's very rare. We have 1 or 2 gynecologists in my community that are savvy enough that once they rule out GYN, they send them to me. But most of the time, these ladies, suffer with chronic pain and they're blown off as, crazy, or you got GYN ideologies.
Yeah, I think that's one of the big access problems for women, for sure. And it's something that I've started doing just literature on, is how an algorithm for management of groin pain in women, because it's something that hasn't been studied or produced, and yet we have that in men.
Thank you very much. All right. By the way, sorry I had to cut you off, but if you take time at the end, please ask that question again. My apologies, just to make us timely for lunch purposes. All right, our next talk is socioeconomic impact on presentation and hernia management by Courtney Collins and colleagues at The Ohio State University Wexner Medical Center.
Good catch. It is The Ohio State. We trademarked the word "the." Let's look. Yeah, thank you. Hold your applause. So my name is Courtney Collins. I'm from The Ohio State in Columbus, Ohio, and I'm going to be talking about how socioeconomic status impacts the presentation and management of the hernia patients we see. So I'm going to start off by talking about money. And despite the fact that we all like to tell our children that money doesn't matter and doesn't buy happiness, money buys a lot of stuff. It makes a lot of things automatically better. If you have more money, you live in a nicer house, you drive a nicer car, you probably go to a better school, you go to a better college, you get a better job. But it affects things as simple as, access to nutrition and food and clean water and that sort of thing. And so this leads to really disparate health outcomes. I don't think anyone here is going to argue with me that if you have more money, you're less likely to die of cancer, you're less likely to die of stroke, you're less likely to die in childbirth, and you're less likely to die after surgery. And so why this happens is really important, though. It's not just the money, right? It's not your nice house. It's not your nice car. It's not your bank balance that's protecting you from these disparate outcomes. It's the different worlds in which we move. And that's what I want to start off talking about. Patients with lower resources have a lot of different barriers that we don't often appreciate as physicians. They have a lack of access to healthcare, which is often due to not having insurance or just proximity to major tertiary care centers. We see a lot of low health literacy. They don't understand